Welcome back to Everything Optometry. Today we're jumping straight into a super high-yield explainer all about threshold perimetry. We'll be looking at how it evolved and, more importantly, how you actually use it in clinic. So whether you're an optometry student cramming for exams, a pre-reg just trying to survive your clinical placements, or a newly qualified optometrist, this explainer is packed with the exact gold nuggets you need.
So, have you ever wondered how a visual field test that used to take an absolutely agonizing 13 minutes per eye can now be breezed through in just 4 minutes, completely without losing accuracy? Or, why modern machines like the Humphrey field analyzer somehow seem to magically know what a patient is going to see before they even press the button? Well, the secret is that modern visual field machines don't just test patients anymore. They actually make incredibly intelligent predictions.
In this explainer, we'll be covering first, the jump from guesswork to smart predictions. Then, we'll look at SITA, ZATA, and GATE. After that, choosing your test grid, avoiding common clinical mistakes, decoding reliability indices, and finally, the learning effect versus the fatigue effect.
All right, part 1, guesswork to smart predictions.
To really grasp why threshold perimetry is such a game changer, imagine trying to find the absolute lowest volume where you can just barely hear a sound through your headphones. Threshold perimetry does exactly that, but, with light. By pinpointing the precise decibel level a patient can see at dozens of specific locations, we can compare those values against a massive database of normal visual fields. This is how we catch incredibly subtle disease progression. But how do these machines do it so fast? Well, think of a paper bag holding 5 balls that are either red or blue. If you have no idea what's inside, guessing you'll pull a red ball is just a blind 50-50 shot. But what if you know beforehand that there's exactly 1 red ball and 4 blue ones? And say you've already pulled out 3 blue ones. Your prediction for that next draw completely changes, right? Just like drawing balls from that known bag, modern visual field algorithms aren't starting from scratch. They use everything they already know, things like normal vision data, age, neighboring test points, and typical glaucoma patterns to make really smart predictions.
Moving on to Section 2, SITA, ZATA, and GATE.
Those exact probabilistic ideas we just talked about gave birth to some of the absolute most important innovations in our field. Meet SITA. And yeah, while it hilariously shares a name with an Australian waste management company, the Swedish interactive threshold algorithm is definitely not a garbage truck. SITA was built for the Humphrey field analyzer, and it literally revolutionized everything. It relies on maximum likelihood estimation and Bayesian probability. Basically, the machine is constantly asking itself, based on this patient's age, our normal databases, and how glaucomatous defects usually evolve, what is the most likely threshold right at this exact spot? It's so smart it even adapts to the individual patient's reaction time.
You'll definitely want to memorize this exam cheat sheet. Just look at the progression. The old-school full threshold testing, with its 4.2 decibel staircase, was super accurate but took a frankly painful 13 minutes. Then FASTPAC came along and cut that down to 8 minutes, but it sacrificed some accuracy to get there. But then look at SITA. SITA Standard gives you that gold standard full threshold accuracy, but in roughly half the time, about 7 minutes. And SITA Fast? It actually matches FASTPAC's accuracy in a blistering 4 minutes per eye, simply by accepting a slightly wider error margin. It's brilliant.
So let's look at the next generation to see how these algorithms evolved even further. Think of ZATA, which you'll find on Henson parameters, as kind of like SITA's smarter, slightly younger cousin. It actually stands for Zippy Adaptive Threshold Algorithm. It's totally unique because it uses the previous visual field results for that specific patient as its starting point. Plus, it smartly adapts its effort. If a spot's sensitivity is totally normal or completely dead, it doesn't waste precious time trying to get a highly accurate threshold there. It focuses all its effort right in that sweet spot where change is most likely to happen. Meanwhile, we have GATE, found on octopus machines. GATE literally learns from the individual patient. Instead of starting from age-matched norms every single time, after an initial seed point examination, GATE actually remembers the patient's exact thresholds from their previous visits.
Okay, Section 3, choosing your test grid.
A really crucial skill is knowing which grid to actually select the moment your patient sits down in the chair. Let's play a little game of grid matchmaker. Say a patient comes in with suspected glaucoma. Which grid are you choosing? You're going to go for the 24-2 or the 30-2. Now, what if it's a suspected neurological defect? Again, the 24-2 or the 30-2 are your best friends there. But what if you are investigating a purely macular pathology like plaquenil toxicity? Well, that's when you call in the 10-2. Just remember this clinical tip. The 10-2 is your central vision specialist. It has 69 points packed tightly together just 2 degrees apart. The 24-2 is your absolute daily clinic workhorse, and the 30-2 is your wider field investigator.
All right, Section 4, Avoiding Common Clinical Mistakes.
Let's step into the Hall of Shame and review the hidden factors that can completely ruin your visual field results. You know, setting up the patient properly is literally half the battle. Imagine you're rushing in clinic and you completely forget to put in the correct reading ad for your presbyopic patient. They're viewing a target at 33 centimeters, so they absolutely need near correction. A simple +4 diopter defocus blur will totally nuke your patient's sensitivity by a massive 6 decibels. I mean, that is enough to make a perfectly healthy eye look distinctly abnormal. You always have to use the optimum refractive correction. Full aperture trial lenses are great, but whatever you do, never ever use progressive or tinted spectacles for this.
Take a look at this prime example of a setup failure. If the trial lens is pushed too far away from the patient's eyelashes, you end up creating this massive, artificial ring of vision loss. We call this a lens rim artifact, and let me tell you, it completely invalidates your statistical analysis. The lens always needs to be moved right in so it's just barely clear of the eyelashes.
Another super easy mistake comes down to patient posture. You really must ensure the lateral plane of the perimeter is completely consistent with the line of their head. If their head is turned or tilted even a little bit, you risk artificially inducing visual field defects simply because the bridge of their nose or their brow bone is physically blocking the stimulus. Posture absolutely matters.
Section 5. Decoding Reliability Indices. Okay, so now that your patient is set up perfectly, remember, the machine is always watching. It monitors fixation using either an optical video sensor to actually track the eye or by using the incredibly clever Hyocraco method. So how does Hyocraco actually work? Well, the machine smartly projects a stimulus directly into the patient's physiological blind spot. If the patient is staring straight ahead exactly like they're supposed to, they shouldn't see a thing. But if they press that button, boom, a fixation loss is recorded because it means their eye must have drifted to look around.
Now listen up, because here is some absolute high-yield exam gold regarding catch trials. A false positive is when you have a trigger-happy patient pressing the button when absolutely nothing is there. On the flip side, a false negative is a patient missing a super bright stimulus in an area where we already know they have perfectly good vision. Seriously, write this down. High false positives will underestimate diffuse and focal loss, meaning they actually make the visual field look artificially healthy. But high false negatives will actually overestimate the visual field loss, which makes isolated defects look like massive widespread damage.
And finally, Section 6, Learning Effect versus Fatigue Effect. Let's move into our final high-stakes segment. This one is an absolute exam favorite because, let's face it, humans aren't perfect test subjects. First up, we have the learning effect. A patient's sensitivity actually improves over successive examinations as they figure out how the test works. The maximal improvement almost always happens right at their second exam. This is exactly why if you find a mild suspicious defect on a first-timer, you absolutely must repeat the exam a few days later. On the flip side of that, we have the fatigue effect, where sensitivity steadily decreases during a single prolonged exam, and this hits the peripheral field the hardest. You can literally see this cortical fatigue in action when looking at the data. Notice how the mean sensitivity drops across the stages, from the first eye tested to the second eye. Because this fatigue is cortical in origin, happening in the brain, it actually transfers between eyes. This is undeniable proof of why you must keep the order of eyes examined constant between visits. Think about it. If you test the right eye first in January, you better test the right eye first at their follow-up in July. Otherwise, the fatigue effect is going to mimic disease progression in whichever eye goes second. Seriously, give your patients breaks.
So, we've gone all the way from blind probability bags and agonizing 13-minute marathons to smart SITA algorithms, perfectly chosen test grids, and navigating the treacherous waters of clinical artifacts. The next time you're staring down a visual field printout in clinic, I want you to remember this journey from guesswork to probability. Look closely at those reliability indices and ask yourself, are you actually looking at true blinding disease progression, or did you just forget the patient's reading glasses? Keep learning, keep asking questions, and I'll see you in the next explainer.